You want to carry on, Chetan? Those who are attending the AHP session can log out and join the AHP session. That should go live anytime now. And we can continue on the doctor session here.
Yeah. Hello, and good morning, afternoon, or evening, whichever part of the world you are all in. And that's one of the points with Zoom. I would like to start the session on medical legal aspects in bariatric surgery. And I have, I think, quite renowned medical legal practitioners from the UK here, and I'll start introducing them. I would like, first of all, to welcome Mr. Ahmed. He's one of the council members of BOMS. He's one of the first Royal College representatives from bariatric surgery, I would say, and well-renowned in medical legal practice. So welcome, Professor Ahmed. He's a bariatric consultant at Imperial.
Thank you.
I would like to introduce Mr. Omar Khan. He's bariatric consultant and lead at St. George's Hospital and well-renowned surgeon in London. He again is quite proficient in medical legal aspects. Welcome, Omar.
Hello.
And last but not the least, I would like to obviously welcome Professor Marcus Reddy. Again, he's a bariatric consultant, popular, joining here today as a medical legal expert. He again is the lead bariatric surgeon at St. George's Hospital. Welcome, Marcus. The stage, or rather the Zoom, is all yours.
Thank you, Chetan. I hope everyone can hear me. If there are any issues, please let me know. But I've been asked to give a rather provocative talk entitled "How to Avoid Being Sued in Bariatric Surgery," which is obviously something we're all interested in doing. So the first question really to ask is, do we actually have a problem with bariatric litigation? Bariatric operations are one of the most best evaluated procedures performed worldwide. Unlike most operations, we've got a really solid evidence base. We've got excellent registry data. We know our patients are really happy. I mean, we know that we have excellent short-term metabolic results and very good long-term weight loss results. So it's odd that we're now talking about bariatric litigation with an operation which is well-resourced, well understood, and popular with patients. And if you actually look at the litigation issues, there's a very nice paper by Ratnasinghe from Ashton and Peters published in 2017. What they did was they looked at all of the bariatric medical legal claims of the NHS over a 10-year period. And actually what they found was they only found 7 claims over a 10-year period, and this was published. The total payout that the NHS gave for bariatric litigation was £210,000 over this period. Now, compare that to, for example, urology, where there was a £20 million payout in total over that period. You might think, what are we wasting our time talking about? There's really nothing to worry about. However, there's a well-known economic phrase called the wisdom of markets, which says this: forget about literature, forget about reviews. If you want to find out what's happening in the world, look at the markets, follow the money. And this is a nice paper from Dalal et al. Instead of looking at the literature, they did a survey of the ASNBS members. And they asked a simple question: how many of you had litigation issues? And they got a 20% response rate. And what's interesting is that of the surgeons who responded, the average number of cases was 1.5 over a 15-year period. So pretty much every surgeon who responded said, yes, I've been involved in a case. Now, interestingly, only 18% actually went to trial, but the average payout was very high at £250,000 per case. That's just payout to the claimant. And as a consequence of this, when they asked the question, well, how much do you pay for insurance? It was £59,200 on average, and this is in 2013. So that did tell us that clearly there's a problem, because if litigation isn't an issue, why are the malpractice insurance charging so much? Now, the interesting thing is, before I did this talk, I actually went online to try and find out how much is the average malpractice insurance. It's incredibly difficult to do. The only data I could find out was from Texas. And in Texas, apparently the average malpractice insurance for bariatric work is $90,000 per year. That's a huge amount of money. Interestingly, when I tried to do the same thing in the UK, it's impossible to do it. And that tells you something. If you want bariatric insurance in the UK for private practice, it's bespoke. You have to phone them up and get an individual quote. The only other specialities which demand that are cosmetics and obstetrics and gynecology, and we know they're very high litigious cases. So there clearly is a major problem. If you can't get simple insurance for a procedure, we know we've got a problem. So what are these problems? I mean, how do we quantify them? How do we classify them? Well, there has been some research on it, and I've just summarized the literature just so that we get an idea of the issues we're talking about. So the biggest series actually is from America from quite a few years ago. It's in the early 2000s by Cotta. And they looked at 100 cases which had gone to litigation. And interestingly, they found 53 deaths, a very high death rate. And they found malpractice in 28 cases. So in 28%, there was actually an issue of malpractice, which was either conceded or given in trial and concluded. What they concluded was that low volume surgeons were the most likely to be involved in lawsuits. But overall, they concluded that the majority of cases weren't negligent, but nonetheless still were litigated. And this is similar to work by Bruguera from 2001, which is a Spanish study. And again, they looked at 49 cases. They found malpractice in 20% of cases, but again, a very high mortality rate, 47%. Now, if you look at more recent literature, there's a nice study from Cassier et al. Based in France, and they went through legal documents to find any bariatric related operation. They went through general surgery, and what they found was that there were 81 cases of bariatric surgery, which represented a very high proportion of the general surgical population litigation. In other words, bariatrics, far from being a small portion of general surgery, is actually a significant portion, more than you'd expect. And when they looked at those cases, the most common reason for a malpractice claim was a leak. The majority of cases were against surgeons, but interestingly, they were finding over the recent years, there's separate litigation against anaesthetists and ODPs and surgical staff. So it's not just the surgeons now are being sued, the staff, related staff are being sued, anaesthetists and the surgical team. And what they found is it was a delay of 2 years between the complications and allegations. In other words, there were patients who were having a complication, were quite happy to be managed by the surgeon or surgical team for that complication. And the minute they were discharged, were then going away and suing, which tells you something about the sort of the dangers really during litigation. You don't end just with the complication. You're responsible for it afterwards, and often the litigation happens after the complication has been managed and some time after. And this is another study from America this time, which was Chowdhury et al. From 2016. They looked at 140 cases and they reported deaths in 52%. So again, very high death rates. The most common reason for malpractice was a delay in diagnosis or management of a complication, typically a leak. And when they looked at what actually happened to these cases, 47% were decided in favor of the claimant. And the median payout was $1 million. So these are very, very big payouts. And when I was doing my research, apparently the world record at the moment for bariatric litigation is $183 million. And I'll repeat that again, $183 million. Now, that was a successful claim done in Florida. The way the American system will work is they will almost certainly not get all that money. It goes to appeal, it gets reduced. But that just gives you a flavor of how much money is involved in these cases and why, frankly, our insurance levels are so high. So we have this paradox that bariatric surgery is so good. Why are we seeing so much litigation costs? And I emphasize the word costs, because I don't think we're having that many cases. It's just that the costs are very high. And I think the reason for that is several-fold. We've got the patients. In compared to general surgery, our patients are younger. And as a general rule, we know that younger patients are more litigious. In other words, if there's a problem, they're much more likely to sue than, say, an older patient undergoing, for example, a colorectal cancer procedure. The patients are very knowledgeable. The average patient spends 1,500 hours online researching surgery before they actually commit. That's from a couple of studies. So in other words, these patients are very knowledgeable. They've got access to support groups. They've also got sort of a bariatric identity. They're very proud of the fact they've had bariatric surgery, or very much label themselves as bariatric surgeons. And if you're in a support group where everyone's talking about how great their results is and how fantastic they feel, if you're having a complication, feeling pretty rotten, that's not going to make you feel good. It's going to make you want to question what's happened. And there's also an issue with rationing. I mean, we all know about waiting lists. I think the current waiting time nationally is going on for 3 years because of COVID. And that obviously engenders some irritation amongst the patient, to put it mildly. And if they then get a complication, having waited for years and years, you can understand why they're keen to complain. And similarly, if you're a private patient and you've dipped into your savings to pay for an operation, and it goes wrong, you are potentially going to be more litigious and potentially wanting to work out what's happened, what's gone on. And of course, the aftercare is very difficult, different to the traditional paradigm of resectional surgery. Vast majority of surgery, you do the operation, and if it goes well, within 30 days, you can effectively wash your hands of it. So you do an appendix, and assuming it's all fine, that's the end of it. Even with cancer, you take the cancer out. If there's a problem, you refer on to the oncologists. But our operation is very different. They require lifelong follow-up. And the complications can occur years after surgery, things like internal hernias. And these patients are physiologically brittle. In other words, if they do have a complication, either early or late, they often will respond badly to it, and they'll have major complications and sequelae from that complications afterwards. So in other words, we've got a young population who, when they have a complication, will not typically pass away, but will be severely disabled after surgery. And these patients, understandably, often are keen to seek legal remedy. Now, the question I was originally asked was, well, how do you avoid being sued? So what I've done is I've reviewed a personal series of my own and Marcus Reddy, who's obviously on the panel, our medical legal experience over the last 8 years. And instead of actually going through the numbers and the figures, because obviously the previous lectures have done that, what I've tried to do is get a flavour of what we're seeing, what's changing, and to answer the basic question, how do we avoid getting sued? So when we look at our own personal series, we had 120 cases over 8 years. Now, 10% of them did result in deaths, but the majority of the litigation we're now seeing actually relates to late complications. And we saw breach of duty of care in about 25% of cases. Now, what that means is 75% of the time, actually the complications were completely reasonable. However, it's important to note that these patients still sued. They may not have won, but they still sued, which shows at the very least significant patient dissatisfaction. So what we have done after this is had a look to see, all right, what trends did we see over our 8-year period? And let's start with the positives. So we're seeing quite a few good trends. So we're seeing fewer inappropriate surgical candidates. We were getting patients with BMIs of 28 and 29 who were being offered surgery and inadequate counselling associated with that. We're not seeing that anymore. I think the NICE guidelines have been followed, broadly speaking, more closely over the last decade. We're seeing fewer technical errors. The roux-en-eau, which is the joining of the biliopancreatic limb to itself, which was quite common when we first started in some of the litigation cases, seems to have disappeared. Unfortunately, we're not seeing any indefensible surgical errors. We're actually seeing fewer band issues. There was quite a lot of litigation about slip bands and poor weight loss following bands insertion. We're not really seeing that anymore, and I think that's just a reflection of the national picture in terms of the reduction of the number of bands we're seeing. So I don't think there are fewer band issues, it's just we're seeing fewer bands being put in. And most encouragingly, one of the most common incidences we were seeing in litigation was failure to rescue. In other words, a patient who'd have a leak after bypass and would end up being passed from pillar to post, from GP and then to A&E, with no one actually picking up that they were sick until far too late. And that failure to rescue seems to be less common now. We are seeing many more patients who are being appropriately triaged in A&E and then referred back to a bariatric surgical service. So that's the good. What about the bad? Well, the new features we're seeing an awful lot of consent issues. And really, the consent issues, and we'll be talking about that in a bit more detail, but the consent issues are now a major, I would say the predominant part of our practice now in medical legal work. And the consent issues vary from a failure to follow a range of surgical options to full discussions about surgical procedures and their risks. And I'm going to give some case examples afterwards just to demonstrate that. We're also seeing more issues related to follow-up. So in other words, a failure to provide emergency provision. So we're seeing litigation against surgeons where we're being told that they did an operation but had inadequate follow-up, particularly in the private sector, and inadequate emergency provision. In other words, a surgeon does an operation a week or 2 weeks later, the patient has a complication and not available. And we're seeing quite a few of those being referred for litigation, and also we've had a few to the GNC as well. And we're also seeing issues with longer-term follow-up. In other words, a patient getting a nutritional problem after surgery and then not having the appropriate follow-up by either the surgeon or the GP and that being litigated. On that note, we're seeing quite a few litigation cases against non-bariatric surgeons, and our GP colleagues are now getting quite a few cases, and also the non-specialist surgeons. So in other words, a surgeon where a patient turns up to A&E and is seen by, say, a breast surgeon or colorectal surgeon, and their management is criticised. And we're also seeing the beginnings of litigation against clinical nurse specialists. I've been involved in at least 2, where their actions, particularly with related to bans, being criticised. And the other thing we're beginning to see now, and I think it's certainly going to be post-pandemic, a major issue, is systemic institutional failures. And that really boils down to access to surgery. The NICE guidelines are very clear as to who should and shouldn't have surgery. They're published. And the problem is, if we're getting to a situation where the access to surgery is being compromised because the BMI guidelines aren't being followed, we're going to see litigation, and we're beginning to see that. The other thing we will probably see a bit more of is the waiting times. Now, this has been an issue in the past with gender reassignment surgery, and the High Court have actually ruled that if you have a waiting time which is clearly excessive, you're depriving someone of their option to have surgery. That is negligent. And given the current waiting times of issues related to bariatric surgery, particularly, we talk about waiting times of 3 to 4 years, it would be reasonable for a judge to conclude that that is depriving someone of surgery, irrespective of whether or not we've had a COVID outbreak or not. And I think that's something we are going to be seeing more of. So I'm going to do a little bit about consent, and then I'm going to ask my colleagues and the expert colleagues in the panel for a view. And I think the first thing we're going to start talking about really is, what is consent? Now, consent in the UK, and I'm looking at UK principles, has really changed over the last decade or so. Traditionally, it was very easy. The test was, what would another surgeon do? And it's been quite easy in the past to do that. You ask what another doctor would do. And the case which really started this off was a case of Hatcher versus Black. It's a very sad story. This is a woman who was a Radio 3 presenter who went for thyroid surgery and wasn't told of the risk of a recurrent laryngeal nerve injury. Now, we regard that as ridiculous, but actually the surgeon said, I never tell them because it's very rare. He got 3 of his mates to come to court to say, yeah, I never tell them either. And the judge held, well, if he doesn't say them and 3 or 4 of his mates don't say them, that's absolutely fine. Now, that was criticised at the time, and it's certainly now really in the history books, as I think it should be. The next case which sort of looked at this was something called Bolitho versus Bethlehem. And without going into the details of it, what the High Court said was, yes, it's absolutely reasonable for you to say other colleagues do the same thing, but it must be logical. You can't just say, well, I don't do it, my colleagues don't do it, but actually it's just principle and it doesn't have any logical basis. But the big case is Montgomery, and most of you will know about Montgomery. Most of you are well aware of the Montgomery principles. And the key point about Montgomery is they changed, the law lords took a view of changing the consent. And instead of being based on what doctors or other doctors think is reasonable, they said the test should be the prudent patient test. What would a prudent patient do in these circumstances? More importantly, what would a prudent patient want to know? What risks should they be told? And what would they, as opposed to what the doctor thinks they would want to know? Now, as a consequence of the Montgomery case, there have been lots of litigation related to consent. And when I was doing the literature review, the vast majority now of medical legal cases now all revolve around consent. And I've listed 3, I think, important cases which are worth investigating and discussing. So the first is Chester versus Ascar. Now, this is a case of someone who had spinal surgery and had a complication. Now, what the judges held was that the complication was not negligent. It was a completely reasonable complication, but she wasn't told about that complication. Now, when they put the patient on the stand, she said, look, I would have probably, had I been told, I would have probably still had surgery, but I may have had it a bit later. So traditionally, you'd have thought, well, she was going to have surgery anyway, and she'd had it later, and it was a non-negligent complication. What's the issue? The case should be dismissed. But actually, what the law lords held was that the doctors or the hospital were responsible for bad consenting, and in some senses, they needed to be punished. There needed to be some consequences. So even though they held that the complication wasn't negligent and the patient had probably had surgery later anyway, they felt that it was really important that the claimant got compensation on the basis that her consent was invalid, even though on a practical level it wouldn't have made any difference. Now, another case which has hit the headlines is a similar one, where Jones versus Royal Devon Hospital. Now, this was a patient who again underwent spinal surgery, and in this particular case, the surgeon that she wanted wasn't available, and she was given the option of effectively going home and having her operation cancelled, or having it done by another surgeon. So she chose the other surgeon on the day. The surgeon had a complication, which again was held to be non-negligent. But again, the feeling was that she wanted that specific surgeon. The fact that she didn't get that surgeon meant that her consent was invalidated. And even though the consent was invalid, even though the complication wasn't a particular medical complication, which was due to negligence, the feeling was she deserved a payout. That was fundamentally the view of the law lords, that her consent is invalid, so she deserved a payout. Now, this all does sound a bit odd, because what we're saying to patients is that even though it wouldn't have made a practical difference, we're effectively punishing the hospitals and the surgeons for failing on consent, which actually goes against most legal principles. We have to show damage. It's not enough to say someone did something to you which was wrong, you have to show damage. And that has been addressed in the very latest case, which is Ducci versus Worcester Hospital. And this is a post-cesarean section patient who developed a complication which she wasn't informed of. But the feeling of the law lords here was that, yes, she wasn't informed about it, but it was very rare. And more importantly, she needed that cesarean section. And therefore, even though the consent was poor, they were not going to effectively punish the hospital for poor consenting. So I think the pendulum has swung a little bit towards hospitals after the Chester case, which caused quite a lot of waves in the legal community. But we still are in a major problem with consent in general. Now, just as a quick thing about being sued, because I think most of us in the audience probably have been involved in some legal cases, but many of us haven't. And I think it's important just to highlight or nail some myths which people have about medical legal cases. There's this idea that in a medical legal case, it should produce a just outcome. In other words, a fair outcome. And sadly, that's not true. The court is not interested in the hospital IT system. It's not interested in the fact that you were on call the night before. It's not bothered. All it looks at is the particular set of events and what happened. They're also not really interested in whether or not you think that liability should be conceded. In other words, if a clinician holds his hands up and says, actually, I think we should just let this go, the court isn't interested, the trust aren't interested. Admissions of liability by the clinician are almost irrelevant. Whether you want to fight it or not fight it really is not a relevant factor. It's a trust to make the decision, or the hospital and the claimant. The other really important thing to say is prior behaviour is not relevant, by which I mean when surgeons write letters saying, this is the first time I've ever had a complication, I've got a very low complication rate, I've got the best results in the country, none of that's of any relevance at all. Similarly, if someone says, well, he's always having those complications and that's why I'm suing, that's irrelevant as well. It's always a case that it's this case and your management in that particular case on that particular day. Anything you did before, during, or after is irrelevant. And there's also this idea that most cases get to court. The vast majority don't. It's typically less than 20% of cases actually get to court. In the vast majority of cases, it's decided beforehand. And the last thing is that people have this idea that there's strict rules regarding what is relevant standards, what is appropriate, what is inappropriate. And sadly, the answer to that is not. There is often major debate between the expert witnesses, and there are actually, to date, no real relevant standards. So what I thought I would do to illustrate this point is I'll do two case presentations. And what I'd like to do is present them, and I'm going to sort of act as devil's advocate and put forward the claimant's view in each case and ask our expert panel what they feel about these cases, their initial impressions. Now, these are invented cases, but they're synthesized from true cases. So what we've done is I've taken bits and pieces from various cases to try and illustrate the principles. But I don't think there's a right or wrong answer here. I'm just simply pointing out what the issues can be and how difficult they can be to untangle. So I'm going to start with this one, which is case one. This is a 35-year-old female, BMI of 42, referred for NHS bariatric surgery. So she was in clinic and she was offered a laparoscopic sleeve gastrectomy, and she was given an information sheet. And on the day of surgery, she came in and she signed a consent form for an antral excising sleeve gastrectomy, and it's signed by the clinical fellow. So 10 days after surgery, she now presents to a local A&E with severe sepsis. And she gets admitted, and laparoscopy reveals a proximal sleeve leak. She goes to ICU, spends 2 months in hospital, and has ongoing psychological issues related to her leak. So the first allegation which came through, she sued, was this. And it was quite an interesting one. What they said was that the surgical technique used by the team was inadequate because they did not use a staple line reinforcement. And had this been done, the leak would have been avoided. So what I'm going to do is I'm going to open it up to the panel of Mr. Agrawal, Mr. Palmer, Mr. Ahmed, and Mr. Reddy. And perhaps I can go and whoever wishes to go first can raise their hand and give their view about this allegation. Should I start? Ahmed, would you like to kick off?
Yeah, sure. Well, first of all, Omar, you made a really fantastic presentation. So thank you very much indeed. Now, when it comes to complications, and I think you alluded to this in your talk, it's the fact that the patient had a leak. That's obviously it's a known complication after any kind of stapling bariatric surgery, and the issues really surround or to do with this particular phenomenon of leak is not so much the complication happened, but was there something to do with the surgical technique that resulted in it? And number two, was there a delay in picking up the complication? Because obviously if you treat a leak soon, within a matter of 24, 48 hours, the outcomes tend to be much, much better. So you can even avoid ICU, for example. So I think the issues here are to do with surgical technique, delay in diagnosis, and also when you go back about the consent part was the patient offered alternative procedures, and was she adequately informed of the possible risks of leak and the consequences of leak, such as what happened in her case? So there's quite a few issues in this case. Now, with the specific allegation, the staple line reinforcement is very interesting because obviously there's a debate amongst bariatric surgeons, with some surgeons using it and others not using it. And I go back to your initial point in your slide, which you mentioned about the process of consent and about the use of logic about making a decision. So the question is, is there a rational or logical use supporting the use of staple line reinforcement? So the claimant could argue that there is evidence and logical use for using staple line reinforcement. So they have a point from that aspect.
Yeah, I mean, certainly that was the point they made. They didn't argue that there was a delay. What they said was that the lack of staple line reinforcement was negligent. And interestingly, the legal test is not that the leak would have been avoided. The test is if you accept that the technique was negligent, then all that the claimant has to prove is that the negligence had a less than insignificant effect on the leak rate. So it's not even as if you can say, well, even if we had used buttress, the leak rate would have gone down from 2% to 1%. That's enough legally to say, well, that's it, because it was negligence. Marcus, have you got any views on this? Because I know you take a different view on staple line reinforcement.
Yeah, I mean, I think that we know that there's a whole range of surgeons who use different techniques to try and minimize leak rates. Some oversew. In the past, people have used glue. The buttress materials are clearly more fashionable now. There are studies which show many factors that determine leak rates, one of which is the issue of using buttressing material. We know that in high volume experienced surgeons, the leak rate now is nearer 1%. And we know that one of the largest factors in leak rate, especially if we look back historically in some of the databases going back to 2012, this sort of era, where over 100,000 patients have been looked at. I think it was the MBS QUIP database. We can see that the leak rates have gone down from 2, 3, 4, 5% down to 1% or less. The explanation for that also seems to rely on the individual experience of the surgeon, not just the institution. So I think that the issue is, what contribution does buttress material add to leak rates? And I think when you're talking at 1% levels, there are even studies which show that there's an increased leak rate with buttress material when you're down to the 1% zone of leak rates. So I wouldn't find it concerning if there was no buttress material.
Sanjay, what's your thoughts on that?
I think I agree with Ahmed and Marcus. I think the thing is, you can't say because buttressing was not used and that caused the leak. What it comes is whether the patient was told that the surgeon or I would not be using a buttressing material. For the last 12 years, I've been doing sleeves at least or longer, and I've never used a buttressing material, unlike my colleagues, Ahmed, who I think reuses for every patient. And so far I've been lucky. So I think it's just a matter of telling the patient that I don't use buttressing material, and she wants a surgeon who uses buttressing material, or she can only have surgery with a buttressing material, then she can go elsewhere. But I think it's very difficult to prove or disprove that buttressing non-use caused the leak. That's my view, is that it's very difficult to prove that that caused the leak because buttressing material was not used. I think it's the other issues which caused the leak, like technique or pickup, things like that.
Thank you, Sanjay, because that actually very neatly brings me on to the next point, and you've anticipated it. So the trust wrote back saying that they did not think that buttressing was an inadequate technique, and they said that a reasonable number of surgeons were not using it. They also quoted the National Registry, where it showed that about a third of patients weren't getting buttressing. However, the claimant then re-responded with this. They said that the consent was inadequate. And what they said was that the discussion of staple line reinforcement was mandatory. And they said it on a couple of things. They said the patient was very concerned about the risk of complications and had apparently seen 3 surgeons beforehand privately. Now, this was not included in the NHS letter, and they said that was an example of poor history taking by the original surgeon. He should have put that in the letter or inquired. The patient was given an information sheet which described various technical aspects of the procedure, as did the consent form, which specifically mentioned an antral excising sleeve, but did not talk about staple line reinforcement. And it was known that staple line reinforcement was offered in neighbouring institutions. So the patient is now claiming that had she been properly consented, she could have elected to have surgery elsewhere, and therefore her consent was invalid. So I'll let our experts just digest that slide, and then perhaps Chetan, if you could give some thoughts as to what you feel.
Thank you, Omar. I think it will take me a while to digest this slide, to be honest. First of all, thank you for this eye-opening talk as always, and it highlights how challenging environment as a surgeon we work in. I think that's one of the highlights I'm thinking. Now, here, as we discussed earlier, I think, you highlighted very rightly Montgomery consent things recently, and it's how much we need to tell the patient. So before, I think we used to quote that, okay, if there is a this much percentage of incidence of complications, we quote them 1%, 2%. Now, I think looking at this, even if it's a 0.2% issue, do we end up quoting them? Does that mean actually we need a separate consenting clinics just to go through these minute details? Because let us say of this staple line enforcement was mandatory use they're mentioning. Tomorrow, somebody might ask me what height of cartridge you use, whether you use green cartridge or whether you use blue cartridge, and at what level do we stop, or at how much level should we be giving this information to the patient? Because yes, this patient unfortunately leaked and then looked into this matter, but for the other 99.5% of patients, would that not just have been too much of excess information to digest?
Yeah, I think that's a very fair point. But the problem is, of course, in hindsight, everyone claims various things, and it's understandable. With hindsight, you look and think of things that could have gone wrong. I'll pick Marcus, what's your view? Do you think that this the issues they've raised about consent are valid? Do you think the consent was invalid because of their statements?
No, I don't. I think that this is highly likely not to proceed much further based on this argument about staple line reinforcement. I think that this is where expert witnesses are really valuable in these types of cases, where you have to balance whether this is going to really run as the allegation. I suspect that this patient had impeccable post-operative care, and that they're scratching around for really quite difficult areas to try and look for damages.
I agree.
Ahmed, what's your view on that?
Just to play devil's advocate, the issue with the law is, since the advent of Montgomery, we as surgeons have to give detailed information about surgery, potential complications, and actually how we do surgery. So if this patient claims that had they known that staple line reinforcement was not going to be used, or had they been given the option and informed about the pros and cons of using it, and with that hindsight, if they say that if they had known that staple line reinforcement was not going to be used, they would not have had the sleeve, then unfortunately, from a legal perspective, they do stand a chance of having a claim succeed. So I think we all have to be very careful when we consent our patients, and we have to almost make a judgment call based on who we are consenting, on whether they're the kind of person who would want to know that degree of detail or whether they would not. Because as Montgomery teaches us, every individual patient needs to be seen as an individual, and it is our, we have to make the call on how much detail they would want to know about potential aspects of surgery and complications thereof.
Yes, I think that's a very good point. And I think the other thing I'd say is that this patient was clearly concerned about complications, because she's seen 3 surgeons privately beforehand before bailing out because she was worried about complications. And one of the points the allegations made is the information sheet does describe certain technical aspects of the operation, but doesn't mention staple line reinforcement. They talk about antral excising versus antral sparing. Why didn't they talk about staple line reinforcement? Of course, spinning it the other way, at what stage do you stop? Do you talk about the size of bougie? Do you talk about the type of anesthetic used? All of these things could go on, but there clearly is a balance here. But have we gone too far in one direction, I suppose? Sanjay, what do you think?
The thing is, how much you can describe. The leaflet which I use is 10 pages. It describes most of the things, but I don't think the leaflet describes that I don't use staple line reinforcement. It would be interesting to know the outcome of this. And probably the first thing I have to do after this LIBSS meeting is to add that line in my information sheet to the patients now, that I don't use reinforcement in my life. So I think we should just let me know what's the outcome, so that I can start adding the new line in the leaflet.
Sure. Actually, that's a very good point you raised. I know, Omar, maybe you can educate us and the rest of the audience about these information leaflets. How legally binding are they? And just because you write something on a leaflet doesn't actually mean you've spoken to the patient about it. Is that right?
Yeah, it's absolutely right. In fact, sometimes it's the opposite. So patients who have pre-printed consent forms, for example, that was a big trend a few years ago. So you put absolutely everything down. Actually, in many legal cases, the judge said, did you go through all 35 of them in the morning? And how long did you actually spend consenting with them? And I think in one of the legal cases, the judge said, clearly you haven't gone through all 35 of these pre-printed forms because you only spent 2 minutes consenting. So in some ways, it actually counts against you, because people say actually the consent was invalid and you're doing it's a tick box exercise. So actually, it raises the question of an awful lot of the things we think protect us probably don't. Because the argument is that actually by giving someone a heap of information, you're not actually doing consent, you're abrogating responsibility.
But Omar, my understanding is that we are not expected to do the consent on the day now. We are doing consent prior to the day of the surgery now, which is what I do now. I definitely countersign on the day, but I don't go through in great detail on the day. I get the form signed well in advance of the surgery, and that time when I spend the time, second time or third time, to go through all the steps of the consent.
Yeah, I mean, consent obviously is a process. It's not a singular event.
Correct.
But I think what I thought I'd do, and perhaps Sanjay, we can open it up to the audience, is I think this case is still ongoing. It is a composite case. It's not a true case, and I suspect, as Marcus said, it probably won't go any further. But I think what this case highlights is a couple of questions. So, does discussion of some aspects of the technical aspects of surgery mandate a wider discussion? In other words, would we have been better off telling them nothing about surgery, saying, you're going to have surgery, you're going to have a technique that I know is proven gives a low complication rate, and that's what I'm doing? Would that have been a better approach, actually? And secondly, it's a more general question. Given we're saying that she could have gone to a neighbouring unit, which offered staple and reinforcement, more broadly, is a surgeon now negligent in not offering the option of surgery in another unit? For example, if you're in one unit and your neighbouring unit has a higher volume with better results, are you negligent from a consent perspective in not offering the patient the option of surgery elsewhere where you know the results are potentially better?
That's an interesting point, Omar. And remember, in your slide, you showed us that a prior behavior is not relevant. And I till date thought that if you are allowed to quote your own percentage of complications, so you could say I have had 0.2% leak rate or so, but you rightly said that no, that doesn't matter. And in the same way, does it actually matter that you say my neighboring hospital does this much volume with this much leak rate? Are we now supposed to even know their percentage volumes and their leak rates and complications rate?
Yeah. I think they're two separate issues. The one is that in terms of your management of that specific case, you're right, your previous leak rate doesn't matter, but this is more a general question of consent. So when you're sitting someone down and consenting them, are you obligated to say, look, my leak rate's 2%, but you know what, down the road is a surgeon who does more of these and these, more experience in me, and his leak rate's actually half mine. Do you want to go and see him? Are you not obligated to say that as part of consent? Wouldn't a reasonable patient not want to say, I want the best result, the lowest possible leak rate, and I want evidence, and therefore send me to the one with the lowest leak rate? It's a massive can of worms, but a prudent patient would ask that question. Who's the best? Can I get access to him? And if down the road you've got someone who has got better objective clinical results, are you not obligated to highlight that to the patient and say, you have the right to go and see him on the NHS, or one big NHS?
Omar, there is a message in the chat box from Jeremy Hayden saying, recent case of cardiac surgery supported that the surgeon is not negligent for failing to discuss technical aspects of the operation with the patient.
Yep. Again, there's no right or wrong answers to this. This is an active, ongoing case, and I think the discussion shows that we ourselves, I don't think, have a consensus opinion. But to that general point, Marcus, what's your views about, from a consent perspective, are you not obligated to tell a patient who wants to know what the complications are, that there is the option of going to someone with a lower complication rate, particularly within an NHS structure?
I think to a certain degree, most surgeons already do this, especially when it comes to certain complications and how they're managed. I think if you work in an institution which doesn't have the full remit of support for the patients, it doesn't mean you can't practice bariatric surgery. It means you have to have networks of care. And so we already practice this to a degree. I think the most difficult part is the initial consent for the primary procedure, is trying to work out what it is the patient needs to know in the sort of two-stage part of the consent. And I think that raises the other issue that you raised, which was about effectively pooling patients, where the surgeon on the day is different to the surgeon who performed the first stage of consent in the outpatients. Well, how do you think that will move? Do you think pooling of patients for what is considered complex surgery is going to have to stop?
I think based on the Jones versus Devon case, yes. It is quite clear. And I think the next case actually highlights this issue slightly more obliquely. But yes, I mean, there is an argument for saying that the consents, if you see a surgeon and you want him because he's got good results and you end up seeing someone else, does that invalidate consent? That comes to our next question, which we'll cover in the next 5 minutes. I thought
we crack on with the next case, Omar.
Yes.
Otherwise we'll run late.
Yeah. So next case is so we've got one more case just to chat about, and again just to highlight some of the issues. And no right or wrong answers. I'm really keen to hear everyone's view on it because I don't think there is a right or wrong answer. So this is a 54-year-old male, BMI of 48, referred for NHS surgery, offered a gastric bypass, placed on the waiting list under Mr. A. The patient's admitted on the day and the consent's completed by Mr. A. And he has a Roux-en-Y gastric bypass. And when you go to the operation note, it says surgeon Mr. A, brackets consultant, / Miss B, clinical fellow. So they obviously did the operation together. Develops abdominal pain over the next 24 hours. CT scan shows a bit of free fluid in the abdomen, has ongoing pain, does a laparoscopy at 48 hours. And there's a small enterotomy described as 3 millimeters in the alimentary limb. It was easily visible, thought to be probably related to bowel handling, and it was sutured and a drain was inserted. She went to ICU, but unfortunately developed pretty severe SIRS response, and then ended up with a peripheral neuropathy and impaired mobility. So the initial allegation was that the surgical technique was inadequate, and the leak was probably present at the time of surgery. And the argument was that the presence of a 3 millimeter enterotomy and clearly the failure to detect it at the time of surgery cannot be defended on a technical basis. So I'll pick, Ahmed, would you like to, what's your view on that? A 3 millimeter enterotomy?
Sure. So, I mean, I think we have to go back to the basics. So for a breach of duty, for the defendant, all they need to have is to have, correct me if I'm wrong, but they need to have a responsible body of bariatric surgeons who would basically feel that, you know, that the presence of not being able to detect a leak at the time of surgery was incorrect. So, and I think we can all agree that enterotomies can happen, and a small enterotomy of 3 millimeters can be missed at the time of surgery. And certainly we can all find a responsible body of bariatric surgeons who would defend that claim. So I personally feel that this allegation for breach of duty probably would not even stand. That's my personal view.
Chetan, I mean, taking that view, do you think there is a size of enterotomy which is indefensible? So for example, had it been a 2 centimeter, 3 centimeter, at what stage would, I'm asking a personal question, at what stage would you say that this is probably indefensible? What size of enterotomy would you not be allowed to leave a patient with?
Yeah, I think I kind of agree with Ahmed's view here that yes, enterotomy and bowel injury, as we all put in our consent, is part of known complication with laparoscopy. Yes, I would assume that if you have major tears and you have, you know, avulsed the whole small bowel and things, that probably is negligent. Here, probably I would go a step back and highlight the point whether the Mr. B who operated on the person, whether he actually had that technical ability and whether he was qualified to do the operation. So I would rather go one step back when this case is highlighted rather than size of the enterotomy.
So I know time is getting on, so what I might do is, because you've actually highlighted the next question, which was posed by in the allegations, which is exactly what you said. What they said was the consent was invalid. The patient saw Mr. A in clinic. He saw Mr. A on the day of surgery. He had a legitimate expectation that Mr. A, the consultant surgeon who was experienced, would do the operation. Miss B's involvement in the case, therefore, invalidated the patient's consent. It was unreasonable for her to be involved in the case, full stop. And the fact that it was an enterotomy done, it was unclear from the operation note who did, how the enterotomy happened and whether it was done when Mr. A was in the theatre, whether Mr. A closed. Those details weren't clear from the operation note. What was clear was a significant portion of the operation was done by Miss B under Mr. A's supervision. So he was scrubbed in theatre, but her involvement invalidated her consent. So Sanjay, what's your thought on this allegation?
I think that's a basic principle. If it's a National Health Service hospital, the trainee gets involved, and I do not foresee that any consent is signed by a trainee and the surgeon together. So I think, and the consent form does mention that the surgery may not be performed by the surgeon, but by a trainee alone or in supervision with a concerned surgeon. And if that consent was designed to mention that, and the patient has read that consent form in full, then I see no see why he can't complain and he can pursue this case. For the other thing is the size of the hole doesn't matter. I don't think it's more important that can happen with an operation. But that's my view.
Marcus, what's your view on that?
I think this is going to become more of a problem in the future. I think that patients with Montgomery are going to expect to know who's doing their surgery. And I think the pooling of patients and the named surgeons need to be specified if possible. And if you're not, because you're pooling patients and you're having trainees, I think we need to be very specific, especially because most of us have senior fellows who are at the point now where they're almost independent, and patients expect to know. And I think we should make it very clear that it's a team-based surgical service, especially in the NHS, and that trainees and senior fellows will be performing some or even all of the operation under supervision. So I think it's something we need to learn from.
Yeah, absolutely. And I think one of the issues, again, this case highlights is the question, should all patients be offered a consultant-delivered service? If not, why not? And then if you accept that principle, then what reasonable patient would agree to be operated on by a trainee who by definition is less likely to be competent, or less likely to be likely to have higher complication rates as compared to a consultant? And then from a consent perspective, do we highlight the fact to a patient that you may be operated on by a trainee, by definition will have poorer results than a consultant? And what reasonable patient would say that's fine? I mean, would any of us, for example, if it's one member of our family, we would choose our surgeon and we would not be happy if it was someone who's less qualified? Legally, doesn't every patient have the same right? And I don't know what the answer to that is. It's very complicated, but that is one of the issues that these legal cases are bringing up.
I mean, I think it's, as time goes on, we're going to have to develop our consenting into a slightly more in-depth approach. But I think this issue of who does the operation, because we know, I think, from quite a lot of data about learning curve experience and these things, patients are, deserve to know. And to be honest, I mean, teaching hospitals, we can't rely on the fact it's called a teaching hospital that they thought they were going to be taught on. I think we need to be very explicit.
So that brings a very good question. That does mean, Marcus, that we have to tell the patient in advance who will be the surgeon. And let's say that surgeon has to go somewhere for an hour in A&E or someone, then what happens?
I think that
it's very difficult to run theatres in National Health Service.
Yeah, it's a broader context.
As per plan.
I think that if it's made clear to the patients a team-based service with trainees and senior fellows, and that the operation is supervised with a consultant, then most patients would expect to know this. They wouldn't expect to have a junior doctor perform their operation, even if we felt they're an experienced fellow. I think it's something we can probably learn from.
Interesting, yeah.
And I appreciate time is now getting on, Sanjay, because I think you're looking at your watch nervously. So I'm just going to give a last slide, which is the question which I posed right at the beginning is how not to be sued. And to be 100% honest, looking at the literature, I think the only conclusion I can come to is the presence of a complication per se often triggers litigation, irrespective of whether the complication itself is reasonable or not. And I think in the majority of the issues now revolve around sort of retrospective consent issues, and they now tend to form the focus of the litigation. And I'm afraid the honest answer is if you don't want to be sued, the answer is not to operate. So I don't know if there are any final comments that any of the panel would like to make.
Yeah, no, Omar, thank you very much. I think you've raised really good points, and I think it's evolving. And I think almost if on an annual basis, we all get slightly topped up with the experience from this ongoing precedence that happens with the legal system. It's really helpful. And, many of us are relying on information sheets, which are now many years old, and it should become perhaps an annually reviewed information and consenting process in our institutions.
Thank you.
Thank you, gentlemen. Thank you, Omar. Thank you, Marcus. Thank you, Ahmad, for joining us. I think let's close this session and we can move on to the next session.